So let's talk about membranous glomerulonephritis. Glomerulonephritis. This is also known as MGN or membranous nephropathy. Nephropathy, or that is MN. So what is very common about this is that any patient who comes to our nephrology OP who is older and having a proteinuria, we always suspect membranous nephropathy in these patients, because it accounts for 25% of cases of nephrotic syndrome in adults, which is pretty high. It actually has a peak incidence between 30 to 50 years and is very common in males. So when it comes to male is to female ratio, it is 2:1. So how many types of membranous glomerulonephritis are there? Membranous glomerulonephropathy are there. It can be either primary or secondary. Primary is also known as idiopathic membranous MN. Secondary occurs secondary to many other causes like malignancy. Very commonly we can see it in lung malignancy, particularly lung malignancy, because the first step that we do in patients who's having membranous MN is suspected MN or like biopsy proven MN, we go for an HRCT thorax usually. And then also there can be breast malignancies, colon cancer. Otherwise it can also occur in infections like hepatitis B, syphilis, malaria, schistosomiasis. Otherwise it can also occur in rheumatological disorders like rheumat disorders like SLE. It can occur in RA, IgG4 related diseases. It can also occur in certain drugs, like in Harrison it is mentioned that NSAID use, probenecid, anti-tumor necrosis factor agents, gold, mercury, penicillamine and all can cause this membranous glomerulonephropathy. So these are the main classification of membranous glomerulonephropathy. So coming to microscopy, which the three things that we should check are light microscopy, immunofluorescence and electron microscopy. In light microscopy, there is uniform thickening of the basement membrane along the peripheral capillary loop. So there is uniform thickening, basement membrane thickening, that's all that we have to remember. And when it comes to immunofluorescence, there is diffuse granular deposits of IgG and C3, diffuse deposits. Now when it comes to electron microscopy, we can understand what it is. Very importantly, we should remember that it causes sub-epithelial deposits. So there have been stages. They tell it can be from 1 to 5. There are staging, but that is not followed much. Now, which are the antibodies that are formed? 70% of cases, the antibodies are against PLA2. It is against the M-type phospholipase A2 receptor on the podocytes, and 10% of cases it is secondary to the antibodies are THSD7A, and very rarely there have been this PLA2 receptors are found along with hepatitis B, cancer, sarcoidosis and all. So this is what happens in primary. Rarely PLA2 associated with three things: hepatitis B, cancer, sarcoidosis. Okay. Now there is another, how do these patients present? The common presentation, any adult who's coming with features of proteinuria, very non-selective proteinuria, a patient who's having nephrotic syndrome, In an adult nephrotic syndrome, the most common one is membranous nephropathy, just keep in mind. And there is this 30-30 rule here, 30%, 30%, 30% rule. That is RRR. 30% of the patients have spontaneous remission. Once remission happens, it is good long-term prognosis. 30% of cases, even after treatment, they get a relapse. And 30% of cases progress to renal failure. Okay. So this is the 30-30 rule in the 30-30-30 rule in MN. And then MGN. See, we all know that thrombotic complications are a feature of all nephrotic syndromes. MGN has the highest reported incidence of the thrombotic complications. Thrombosis. So just keep in mind it's very thrombotic for these adults. So we think in terms of renal vein thrombosis, pulmonary embolism, deep vein thrombosis. These are all very common. And who has a worse prognosis? Male gender, old age, hypertension, nephrotic-range proteinuria. Okay. Now coming to the treatment. See, we are anyways going to treat edema, dyslipidemia and hypertension. Okay. Plus, there are two more things that are mentioned. That is, we have to treat them with the RAS inhibition. That is, either AC inhibitors or ARBs and SGLT2 inhibitors. That is, our dapagliflozin and all. Okay. Which patients should you use immunosuppression or not? Specifically, patients with primary MN, you can use immunosuppression. Otherwise, if the patient is having persistent proteinuria, these are the two indications to use immunosuppression agents. And this choice is dependent on the nephrologist who is going to treat. They give steroids, cyclophosphamide, calcineurin inhibitor, rituximab. And so yeah, this is how it is. There is one more question which comes. Patient is having a thrombosis, a highly thrombotic stage. So should you give anticoagulation or not? Yes, anticoagulation is recommended if patient is having hypoalbuminemia. Thank you.